Dr. Altorki, don't sit down. Come up here as you are next to talk to provide a summary of of both of your trials.
Thank you. The previous two papers or three papers sort of set the stage. I don't need to say anything. So I was asked to provide a summary of JCOG. And I would say that JCOG started in 2014, accrued twice the number of patients that CALGB did, and completed accrual in 3 years. CALGB, on the other hand, took about 10 years to finish accrual, about half of the subjects. These are my disclosures. So you all here know that lobar resection has been the standard of care. The sublobar resection is generally relegated to patients who have inadequate pulmonary or cardiopulmonary reserve. And of course, the JCOG was presented probably 2 years ago now and published in Lancet, and the results were transformational. And CALGB was presented at World Lung in August of last year. So just quickly to those of you who are not familiar with the design, so the JCOG was included patients with clinical stage 1A, peripherally located, 2 centimeters in size, and included some patients who had a non-solid component. They were intraoperatively, they write that there was intraoperative confirmation of eligibility, and it's not quite clear to me what was done intraoperatively to confirm that eligibility. The patients were then randomized to have a lobectomy or an anatomical segmentectomy, specifically not a wedge resection. The stratification factors are histology, gender, and age. The primary endpoint is different from CALGB in the sense that it was overall survival, and the secondary endpoint was recurrence-free survival, adverse events, and the proportion of local recurrence and changes in PFTs. So these are the baseline characteristics. I just want to draw your attention to a few things here. One is, I thought I had it marked. Yeah, I do. So about 50% of the patients had solid tumors. The rest had some component of GGOs. And there is good data from Japan, actually, that any proportion of GGO may actually be associated with a better outcome. The other thing I would like to draw your attention to is the proportion of patients here who are never smokers. So more than 50% of the patients in both arms of the trial were never smokers. And finally, I'd like to draw your attention to the high proportion of patients with adenocarcinoma. These are important because generally there is a sense of comparison. People want to compare these results with the results from the American trial, and these demographic and clinical features are important to consider as we do that. So for the primary endpoint, segmentectomy was not only non-inferior, but in fact superior, and the trial was powered for both superiority and non-inferiority. The 5-year survival for lobectomy was 91%, for segmentectomy was 94%, and the one-sided p-value for non-inferiority, as you can see, 0.0001, and for superiority, 0.008. So pretty strong evidence that segmentectomy is better in this setting. There was no difference in recurrence-free survival. That was a secondary endpoint. 88% after lobectomy and 88% after segmentectomy. And then the recurrence patterns. The total recurrence patterns were about 50% higher after this in the segmentectomy group compared to the lobectomy group. Isolated local regional recurrence were 3% and 7%, so slightly higher in the segmentectomy arm. When you combined local recurrence isolated or with any distant recurrence, it was 10% versus 5%. That was statistically significant, but however, as you saw from the survival curves and the recurrence-free survival and the relapse-free survival, that was not really clinically meaningful. What about pulmonary functions? The investigators postulated that they needed to get a 10% reduction or difference in the FEV1 between the two arms of the trial, and that in fact did not occur. There was a decrement in FEV1 at 6 months and 1 year, both in the lobectomy arm and the segmentectomy arm, but the difference, the absolute difference between the arms were rather small, 2.7% at 6 months and 3.5%. That met statistical significance, although obviously not clinically meaningful. There's some interpretation of the results of the trial that therefore lobectomy should remain the standard of care. I fail to see the rationale for that. The curious thing also is that there was a higher rate of death in the in the lobar resection arm. As you can see, 10% in the segmentectomy arm and almost 15% in the lobar resection arm. And that difference was not due to lung cancer-related death, but due to other causes. And it's not entirely clear what those other causes were, or were they in fact impacted by an imbalance in the cardiopulmonary or other characteristics, baseline characteristics of the patients. So it was 5% versus 10%. Which brings us to the American trial, which was started in 2007 and completed in 2017. A labor of love, I would say. So, T1A, N0, 2 centimeters or less, and the size of the solid component had to be 2 centimeters or less. For reasons that are not entirely clear to me then and are still not entirely clear to me now, I chose to stratify the patients by tumor size, and I'm glad I did, by smoking history. Dan, I think you asked a question about smoking, and by histology. Patients were, if they met the preoperative eligibility criteria, they went to the OR, and then they had to have 2 mediastinal nodal stations sampled as well as level 10. And if those were negative, all of them, the patients were then randomized to lobectomy or sublobar resection. And we decided to include wedge here because it's the most commonly performed sublobar resection modality both in North America and in Europe if you look at the registries. If patients had their nodes biopsied by MEAD or EBUS, that was fine. The primary endpoint was disease-free survival. The secondary endpoint was OS, pulmonary functions at 6 months, and rates of local regional recurrence. And here is some important differences. The age, as you can see, is the same as the Japanese trial. In both trials, there was a preponderance of female. We've seen that over the years. More women are getting lung cancer. The 2 arms were perfectly balanced for the 3 stratification factors: tumor size, smoking, and histology. But as you can see from the smoking part, only 10% of the patients were never smokers. So 90% of the patients were ever smokers. And that, I think, is an important distinction. The other important distinction is adenocarcinoma accounted for 2/3 of the patients, not 90% of the patients. I believe that histological subtypes can sometimes be associated with an indolent behavior and may confound the survival. 15% had squamous, and 20% of our patients had other histologies, which are sometimes pretty sinister histologies. So we published and presented the operative data before. Here is the spectacular thing for me: 80%. Now, think about this for a second. This was done in 80 institutions in Canada, Japan, and Australia. 80% of the operations were done minimally invasively. That is a complete transformation of surgical care. The other important finding is, some of you in the room may remember that the mortality of lobectomy is 4%, 5%, and that is a refrain that keeps being repeated, but in fact it isn't. 30-day mortality was 1.1% and 0.6% in the sublobar resection arm. That was not statistically significant, but it is of interest that it's almost 50% less, and so that's something we need to keep in mind. So the Data Safety Monitoring Board reviewed the data, and in May of last year decided that the data can be released to the investigator and that we should present it. So we presented it in the first available meeting, which was the World Lung. And as you can see here, there is an overlap of the disease-free survival curves. The hazard ratio was 1, and the p-value for non-inferiority was 0.01. At 7-year follow-up, the survival rate was 63% and after sublobar resection, and 64% after lobectomy. And I caught a lot of flack for that number, but I'm glad that you guys presented your data before me, so now that we have further validation that that is in fact the case. This is the exploratory subgroup analysis that looks at the impact of various clinical, demographic, and characteristics on DFS. And as you can see, the black boxes, the little black boxes fall right in the middle across almost all of these, including the 3 stratification factors, smoking. So then that sort of answers some of the questions that you may have raised. Smoking is classified into never, current, or former smoker, and histology. This is the overall survival, a key secondary endpoint. Again, the green is the sublobar, the red is the lobar. The hazard ratio was 0.95, and the p-value for non-inferiority was 0.01. It really should not be called non-inferiority because this was a secondary endpoint, so the p-value, they're similar overall survivals. At a median of 7 years, 5-year survival was 80% in the sublobar resection arm and almost 79% in the lobectomy arm. This is the cumulative incidence of death, and I'm sorry that this is a little busy, from lung cancer-related death and from competing causes of death. Now, the dashed lines are lung cancer death. The red is lobectomy, the green is sublobar resection. And if I can point, so this is the lung cancer-related death in the lobectomy group, the lung cancer-related death in the sublobar resection group, and these are the competing causes of death between the 2 groups. And as you can see, even though there is some divergence in the lung cancer death, there is really no difference between the 2 modalities in the competing cause of death of lung cancer-related death. What about recurrence? So that was the big shocker, 30% of the patients. In what we believe is the best of the best, these are the people that we think we could cure them. So 30% had recurrent disease in both arms of the trial. Local regional recurrence was a little higher in the sublobar resection arm, 10% in the lobectomy arm, 13% in the other one, and the p-value was not significant, and similar rates of distant recurrence. So this is the recurrence-free survival. These are data. This data was not presented at World Lung, and as you can see, there is no difference in the recurrence-free survival. The hazard ratio was 1. It was 70% at 5 years in the sublobar resection arm and 71% in the lobectomy arm. What about pulmonary functions? Well, we looked at PFTs, FEV1 and FVC only, and we did them only at 6 months, not at 1 year. And yeah, there was a decrement in both, -6% at 6 months in the lobectomy arm, -4%, very highly statistically significant of dubious clinical value, and the same is true in FVC. So in summary then, in patients with peripheral clinical T1A, and that's really important, the next line is important, without metastasis, confirmed metastasis to the major hilar and mediastinal lymph node, sublobar resection, you can do. If your passion is for segment, that's okay. If your passion is for wedge, that's also okay. It seems to be non-inferior to lobar resection. Disease recurrence, and that is important, it occurs in 30% of the patients. So I think it behooves us to start thinking about whether or not these patients should be participating in clinical trials aimed at reduction of this very high recurrence rate. The absolute difference in FEV1 and FVC is not meaningful, and that raises the question whether we are looking at the wrong metric, because most of us here would think that it does make a difference in a functional point, from a functional standpoint. And of course, it's very reassuring that we have 2 large trials that have reached the same conclusion using different design. And I'll stop here. Thank you.